A very good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Madam, Dr. Urvashi Singh, directors and team from NIRT Chennai and NTI Bangalore, state TB officers, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, and others. A very warm welcome. Introducing faculty from NITRD, I am Dr. Neeta Singla. I am Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Medicine. On my left is Dr. Priyadarshini. She is a pulmonologist at NITRD. I would also like to welcome our director, Dr. Upasna Agrawal, who has recently joined us as the director of our institute. She is a very senior faculty with us and she has been heading the Department of Internal Medicine for more than 20 years. Dr. Upasna also runs a very successful HIV TB eco clinic, the eNishchit. I request her to give her introductory remarks. Over to you, Dr. Upasna.
Good afternoon, ma'am. Thank you so much for the kind introduction. And it is indeed an honor to speak to such an august gathering of TB experts from all over the country. I welcome you all and my special welcome to DDG Madam Dr. Urvashi, who is spearheading the program and leading the country in TB control. Welcome, ma'am, to this session. So as Madam said that I have recently joined as a director of this institute, and I have some experience in doing echo clinics on my own. And actually, I and Dr. Neeta, we had initially started out together. Then I branched out in HIV TB and she branched out in the difficult to treat TB cases. So with these few words and a welcome to all the august people here, I see you have a very interesting case presentation being done from Thane Hospital in Maharashtra. The Dr. Alpa Dalal as the state specialist and the national expert being Dr. Rajesh Solanki. Welcome to all of you to this clinic, and I hand back the mic to the people on the dais. Over.
Thank you, Dr. Upasna. I now welcome our DDG Madam, Professor Dr. Urvashi Singh. She is the head of our NTP family. Her presence is always a great motivation for all of us. We always look forward to her guidance in these clinics. I request her to give her address. Dr. Urvashi Singh, ma'am. I think there is some technical issues and ma'am is there. We can see her name, but we are not able to hear her. So I'll connect as soon as we are able to solve this technical issue. So going ahead with our series, which is...
Good afternoon.
Thank you, ma'am. Thank you for joining us. Yes.
Sorry, I was in many meetings together. So yeah, my apologies.
Sure, ma'am.
So good afternoon to everyone who has joined today, and thank you, Director NITRD, Dr. Upasna, for hosting this effort. For it's like you can count on them to come back with these clinics. Thank you, Dr. Singla, sir, Dr. Neeta Singla, and of course her team. And thank you, ECHO, for facilitating these meetings. I can see some of our wonderful experts have joined online. I can see Dr. Alpa Dalal, who's been one of the contributors to MDR-TB, one of the very committed persons who have taken the cause of MDR-TB forward in Mumbai, contributed to so many people's lives, which I can also say for Dr. Rupak Singla, who continues to guide not only the policy of the program, but also the patient care that he so passionately oversees. And, difficult to treat patients always land up on his door and on the doors of several of our MDR-TB experts across the country. So thank you, sir. Thank you, Dr. Lal, and thanks everyone who's been contributing to patient care in a big way. So these clinics, as I said earlier, has been the contribution of NITRD to, through many, if I may put it. The new director always takes the flame forward, supported by Dr. Neeta Singla, Dr. Sangeeta Sharma, the pediatric TB. And to my mind, thanks to the ECO platform, this clinic can actually reach far and wide to our peripheral level workers as well. Several of our district PB officers join and take back messages which can be useful for implementation for them. Also, the difficult to treat clinics always ensures that they disseminate program guidelines again as a guidance to all our practitioners, be it in the private sector, public sector. So that is one strength which I would like to see, that these clinics have actually extended the purpose of the program, disseminated the guidelines far and wide, and addressed challenges, which can happen in any clinical field, challenges with a difficult case, or where and how to deal with a problem. So basically, this hand-holding effort, this continuing medical education effort is not something simple to do, but again, the team has done it successfully and supported the National TB program in a big way. So, thank you to all. I would like Neeta, kindly proceed.
Thank you. Thank you so much, ma'am, for your kind words. Ma'am, today we are also joined by team from Bhutan, Bangladesh, Afghanistan, and Philippines. The Philippines team is also hand-holding many other Southeast Asian countries for their difficult to treat cases. So, a very warm welcome to the Philippines team and to Dr. Katoch, who has just joined us. Thank you, sir, for joining us. And thank you, teams from Philippines, to join us. So just because we have some new people today, I would like to inform that we invite cases from different parts of the country where they have some difficulty in managing those cases, and we try to share these cases and learn from each other. So in our this series, this time we are discussing a case from Maharashtra, and this is a public-private partnership case, which is like we can learn many things, how the things work in the public-private partnership. So case presentation is by Dr. Sharvari Rathod, who is a clinical associate in Department of Pulmonology in Jupiter Hospital, Thane, Maharashtra. The state expert is Dr. Alpa Dalal, who is HOD Department of Pulmonology in Jupiter Hospital in Thane. And our national expert will be Dr. Rajesh Solanki, who is professor and head Department of Respiratory Medicine at Nutan Medical College in Visnagar. And our DT3C expert, the clinic expert, will be Dr. Rupak Singla. So with this, now I hand over to Dr. Sharvari for her case presentation.
Yes. Good afternoon, everyone. And good afternoon to the esteemed panelists and all the experts present today and all those who are attending. So today I'll be presenting a difficult to treat TB case. Let me just share my presentation.
Do you want us to do the screen share? Do we share your presentation?
Okay, ma'am, if you can share it.
Sure.
Yes. Yes. So I'll start with my presentation. So this is a case. Yeah, am I audible? Yeah.
Yeah, Dr. Sharvati, yeah.
Okay, ma'am. Yeah. So this is a case of a 21-year-old female college student, no comorbidities, no past history of TB or TB contact, no history of addictions. She presented in July 2022 to a private chest physician with the chief complaints of fever, cough, and loss of appetite since 1 month. There was also a 5 kg weight loss that happened in 1 month. She was admitted there in a private hospital, and a CT chest was done over there. So can we go to the next slide? Yes. As X-ray was not available with the patient, we have the CT films. So I have posted the CT films only. As we can see here, there are some centrilobular nodules, some tree buds in the left upper lobe, in the right upper lobe, and the left lower lobe. Can we go ahead, please? Yes, and there was this mediastinal window which is showing some necrotic right paratracheal lymph node also. So can we go ahead? So despite this, the patient was started on first line AKT empirically. She was weighing around 67 kgs at that time, and she was started on first line AKT, isoniazid at 300 milligrams, rifampicin 600 milligrams, pyrazinamide 1750 milligrams, and combutol was 1 gram. So as the patient was not having much of a clinical response, a CT scan was with contrast was repeated again after 3 months, that is in September 2022. And now, can we go to the next slide? Yes, this CT scan is repeated after 3 months in September, after 2 to 3 months. And now we are seeing a right upper lobe cavitatory consolidation and also a small cavity, a small cavity in the right lower lobe and a left upper lobe cavity. And even some nodular opacity is seen in the left lower lobe. So she was not having a clinical response, and radiological, we can see there was some deterioration. Can we go to the next slide? Yes. So now a bronchoscopy was planned by the chest physician over there. A bronchoscopy was done, and BAL came out to be gene expert, MTB detected low, rifampicin resistance was detected. So we don't have the LPA and the AFB culture sensitivity reports. Based on the gene expert report, she was started on second line AKT in September 2022 at the weight of 67 kilograms. So injection kanamycin was added 750 milligrams, ethionamide was 500 milligrams, Tericox 500 milligrams, Monopass was 3 grams TDS 3 times a day, so that was around 9 grams. Clofazimine was 100 milligrams, linezolid was 600 milligrams, and moxifloxacin low dose was probably added 400 milligrams. So, however, the patient took injection kanamycin for 4 months and then she stopped it abruptly. She also kind of defaulted on tablet moxifloxacin intermittently due to complaints of nausea. So this AKT was ongoing from September 2022 and she continued till April 2024, but she was a frequent defaulter. In April 2024, there was some worsening of her symptoms. She had dry cough bouts which aggravated since 15 days. There was high-grade fever with chills since 15 days, and there was shortness of breath on minimal activities since 15 days. So now a third CT scan was repeated, which shows in the next slide, the CT scan is available, which shows again multiple centrilobular nodules, and we can see a left lower lobe dense cavitatory consolidation, and a lot of nodular opacities are seen. So definitely there is worsening in the disease process. Can we go to the next slide? Yes. So now this time, as there was clinical worsening, there is radiological worsening, a second bronchoscopy was planned in April 2024. So this time her BAL gene expert came out to be negative, and the BAL was also sent across for bacterial and fungal cultures. So fungal cultures were negative and bacterial culture grew Pseudomonas aeruginosa, and that was sensitive to meropenem. So at this time, the ongoing AKT that she was continuing was ethionamide, Tericox, Monopass, Clofazimine, linezolid, and moxifloxacin. Along with this, because of her worsening symptoms, she was treated with injection meropenem as per sensitivity of Pseudomonas in her bowel. Eventually, her cough and fever subsided, even her appetite improved, and now she gained from 67, she had gained around 3 kgs more. So now she was 70 kgs. Now, in June 2024, she presented to us in our OPD in the private sector. This time, again, there was worsening symptoms. There is low-grade fever with evening rise since 10 days. There is some cough with streaky hemoptysis since 10 days. There is also loss of appetite. However, there was not much loss of weight. She was at 70 kgs, but there was significant loss of appetite. So, to summarize this case till now, this is a young female with no comorbidities. Initially, she was treated with first line AKT in private sector. There was no clinical response, and as we did the BAL, that was suggestive of gene expert MTB detected REFA resistance, which was MDR-TB. Then she was treated with more than 18 months of second line AKT in the private sector, which she frequently defaulted. And the last bronchoscopy that was done was also suggestive of gene expert, that was negative. And when she was treated for her bacterial infection, she got clinically better, but later presented with worsening symptoms to us in June 2024. So I would like to pause here and ask my experts, how should we proceed now?
Thank you, Dr. Sharvili. So I open the house for discussion on the history of this patient for diagnosis till this point. Are there any questions? Any questions?
Before the first treatment was started, what were the investigations you had in hand?
So, ma'am, first, when she was treated in June 2022, she was given empirical AKT, and that was based on her clinical and radiological symptoms. And later on, a bronchoscopy was done, which was suggestive of MDR-TB. And then a second line AKT was added by from outside in the private sector.
So no investigations before first treatment was initiated, no X-ray, no sputum examination, no quantimetry test, right?
Madam, the CT scan films were available with the patient, so that is what I have put. Her previous X-rays, she has probably misplaced. So I just have the CT scan images that were done. And
why I brought it up was we from the program are encouraging universal DST to be offered right at the upfront universal DST.
Yes,
so I would actually be concerned if that is not being done in a symptomatic patient. In the new strategy, what we have adopted is we are doing active case finding even in the asymptomatic vulnerables by offering a screening by an X-ray. So if the patient was symptomatic and was not offered any of this, then somewhere there is a gap. So I would like to know more about it, which I'll discuss with Dr. Alpa later.
Yes, ma'am.
So, Dr. Sharvili, my question is, sorry.
Just revise the investigations available in hand right now, because you ask what is to be done next. Could you just go over the...
Yes, ma'am. So we had bronchoscopy gene expert report, but LPA and AFB culture reports were not there with the patient. This was in July 2022. She presented to us in June 2024. So the reports that were available and the AKT that was given, as per the records, I have mentioned that.
I've got one question. Nita, can I ask?
Sure, sir, sure, please.
So when the patient came to the hospital, Alpa's hospital, so they straightaway did bronchoscopy. So they did not do, as Madam DDG told, another basic investigation were not taken. So what was the reason? I want to know the reason. Because only Alpa, you are laughing. So I want to know what was the reason, because under the program we have to move according to the guidelines.
Can you repeat your question, sir? Exactly what?
I want to know that once the patient came to your hospital, the why the guidelines were not followed. All basic investigation were not done as per the program.
No, basic investigations are done. Nothing was remarkable, so I have not put it here.
Okay,
All the
okay.
pre-treatment evaluation was done. Here, there is some discrepancy and discordance because the patient has already taken treatment outside, he's already taken second-line drugs, and patient is not responding. And the latest bronchoscopy which was done, which showed that AB smear was negative and gene expert was negative. And when she came to us, the culture report was awaited. So we have a patient who has already taken 1.5 years of treatment. And it was not followed the best guidelines in the private sector. Taken now she's come to us. She's otherwise okay. Her weight is also stable, but she has this persistent cavity which is there in the right left lower lobe, and she's having intermittent symptoms. She is not responding, and she's had a default with the AKT. And that is the reason then we decided that what should be the next step to be taken. Now the patient has come with us. So that is what
Okay,
the
okay. Thank you.
pre-treatment evaluation and the blood investigation and everything was normal.
Okay.
So, Dr. Alba, what I would like to highlight here is that we have two private institutions. Yours is also a private institution, and we had a patient who's been worked up in another private institution. So we have two establishments here. One who is with the program as a partner, who's participating in the program where the patient, all the guidelines are being followed. But this patient earlier went to a private sector, which was not the part of the program, or there is no collaboration with the. So basically, now we have a comparison of both the private sectors where there is a coordination and where there is no coordination. So I would like to highlight that point, that how important it is to be part for a private sector to be part of the program.
Yes, and as you can see, the choice of regimen, and you can make out that the injectable which are not now used in the as part of the program have been used, and patient is not offered to go to a public sector and get the regimen, which is the right regimen for her drug-resistant TB.
Even the dose of economide is low and cycloserine is low because her weight is 67 kgs. So
Absolutely.
she's been given sub clinical doses of even all the three: injectable, economide, and cycloserine.
Yes.
That's what we get.
In fact, the first line AKT dosages were also not according to her weight band.
That is the probably reason the FDC probably was not given, that she was not, and there were no smears in between, no X-rays in between for follow-up. These are equally important to see.
Yes.
Thank you.
Absolutely. So first time X-ray would have been done, she misplaced it. But yes, all the the follow-up, like it should happen according to the protocol and guidelines, clinical, radiological, microbiological, that was not done. In fact, in the very first time, though she had a dry cough, the attempt of sputum induction was not done, and she was directly put on first line AKD without confirming the diagnosis.
So if there are no more queries, can we move ahead, Dr. Alba?
I have one query. Can I ask? Ma'am, is there any history of contact of TB case which is
no, not a known contact case, not a close contact. That's mentioned in the first slide.
And ma'am, what are the causes of frequent default of this patient? Because
so she's a young girl who has been pursuing her college education, and then she's having a partial response, and there was break in her education also, in her career also. So there was a bit element of depression. So all these factors plus side effects of, then I think lack of proper counseling, all that led to default.
Yes, Dr. Alpa, we can move ahead.
Yes.
What was done for the cavity, left lower zone cavity?
What was done for the left lower lobe? So when she came to us and she had this left lower lobe cavity, she's not clinically responding, definitely not radiologically responding. Only thing that it's not supported by a microbiological investigation. And bronchoscopy was showing AB smear that is negative and culture that is gene expert that is negative. Now this was something not fitting in, because if we see the cavity and we can see from the serial CT scan that this looks very much an active cavity. If such an active cavity, if the smear is negative and gene expert is negative, then there is a question whether it is something else than TB that's happening here. So there again, we had a pseudomonas which was positive, and she was treated for pseudomonas and showing some partial response. So that was the
Ma'am,
stage when she came to us.
the thing is that cavity in the lungs is a hallmark of Mycobacterium tuberculosis.
Yes.
This is the only organism which builds cavity in the lungs.
Yeah.
And I have worked 40 long years in this field. In fact, in thoracic surgery, we used to cut cavities and we used to find that there is no blood supply inside the cavity. Whatever the drugs you are giving are not affecting the bunker made by Mycobacterium tuberculosis where it hides, and it develops more drug resistance inside that. In fact, the fungus also grows inside the cavities, causing massive hemoptysis. Now, the thing is that the cavity formation which happens, I could deal with it very, very easily with high dose vitamin D. I mean, cavity is vanishing, not the thick walled cavity, but the
So
thin
here
walled
we
cavity.
are, the point that we are discussing, Dr. Lalit Kumar. Yeah. So the thing
The
is
reason
that
for default is the drugs which are there, like linezolid and whatever it she is taking, they put the patient in depression. We should ourselves eat all these things for 15 days or 1 month to realize what patients are undergoing. And thirdly, there are so many
I
other
think we
ways.
should go ahead with the case presentation. I mean, your point
And
is
there
well
is
taken.
pleural effusion now, pleural effusion both the sides.
It's a breath shadow. That's a breath shadow. There's a fluid level in the cavity on the is what I feel on one side.
Yeah, thank you, Dr. Lalitsa. Your point is well taken, and I think Dr. Alpha will be able to answer it in her presentation when we discuss it further.
I would like to make one more point, Dr. Neeta.
Sure, ma'am.
Since there were cavities, was any like you did fungal culture and you probably did bacterial culture? Did you try looking for non-tubercular mycobacteria? Did you ask for non-tubercular mycobacteria to the microbiologist to look for? Because non-tubercular mycobacteria would colonize the cavity to begin with, but eventually could lead to non-tubercular mycobacterial disease in a non-collapsed cavity.
Yes, I agree with you fully. When the last bronchoscopy was also done in the private sector outside of our hospital. So when at this stage, she has come to us with a bronchoscopy report, and AB culture is not yet available. They had not done NTM PCR, and AB smear was negative on that report, and gene expert was negative. So at that stage, she has come to us.
Gene expert will be negative in NTM.
Yes, gene expert was negative.
So gene expert is not negative in all NTMs. Will pick up non-tubercular mycobacteria when they are in higher load.
Right.
There are several publications available I could share with you.
Sure, ma'am.
Especially abscesses and even a few others as well. But they have to be in a higher load.
Right, ma'am.
But the gold standard would be the culture, because a single culture will also not, according to the American Thoracic Society definitions, there have to be more than one cultures positive. If it is barred, then a single culture, biopsy, single culture, but if it is sputum, more than one culture is required. My only point was we should, I am not really heard the complete history and the way forward, of course, I'll hear you. But then in cavities, and especially because you went for fungal, non-tubercular mycobacteria, unless you request, they may miss it. So it is a good practice to rule out non-tubercular mycobacteria.
Yes, absolutely. Yeah, I agree with you, madam. Should we proceed with the case, or are there any other questions?
I think you can proceed, Dr. Alpha.
Yeah.
Yes. Yes. So now the patient has come to us with the X-ray and the reports right now. And this is where we decided to do a third bronchoscopy of the patient. So based on her persistent clinical and radiological deterioration, and the BAL AFB cultures of the last bronchoscopy were also awaited. So we tried counseling the patient and the relatives. So initially they were a little reluctant to undergo the procedure again, but the importance of doing the bronchoscopy was explained, and then they consented for the procedure. So this time carefully we took the BAL from the left lower lobe cavity, and this is where the gene expert came to be MTB detected low, RIF resistance detected. We also run a expert XTR on the same sample, which came out to be resistant to isoniazid, low level fluoroquinolone, and second line injectables were also resistant, and it showed sensitivity to ethionamide. So the current AKT that she was on from the previous private sector that was ongoing, this is like more than 18 months now, that was ethionamide, Tericox, PAS, Clofa, linezolid, and moxifloxacin. So now at this time, we decided to give her a BDQ based regimen, and we did her entire pre-treatment evaluation was done. And after that, we decided to start her on an all oral longer regimen. So on 22nd of June 2024, her weight was around 70 kgs, and we decided to add bedaquiline, delaminid, moxifloxacin high dose, linezolid, cycloserine, clofazimine, and ethionamide. So initially they were added at the dose of bedaquiline 400 milligrams, delaminid 100 milligrams twice a day. Moxifloxacin high dose was added 800 milligrams, linezolid 600 milligrams, cycloserine 750, clofazimine 100 milligrams was added initially, ethionamide 750 milligrams. And the bronchoscopy that was done by us in June 2024, in July 2024, her BAL AFB cultures came out to be MTB complex positive. And we did a DST on that, a 13-drug DST, and that showed resistance to isoniazid, rifampicin, ethambutol, pizina, kanamycin, amikacin, capreomycin, ethionamide, and levoflox, and showed sensitivity to PAS, clofazimine, high-dose moxifloxacin, and linezolid. So now in the DST, ethionamide showed resistance. In the expert XTR, it was showing sensitivity. So in view of the DST resistance, we stopped the ethionamide. And now her current AKT was bedaquiline, delaminid, moxi high dose, linezolid, cyclo, and clofa, which was continued. So next slide, please. So after 3 months, she did a follow-up. In September 2024, she complained of frightful dreams, some depressive thoughts, and sleep disturbances. So we referred her to a psychiatrist, and tablet cycloserine was stopped temporarily, and she was started on other medications, Quitans, sertraline, and Rivotril for her depression and anxiety disorder. In October 2024, she also complained of bilateral lower limb tingling, numbness, and burning sensations, difficulty in walking, and slippage of footwear. So, suspecting as to be peripheral neuropathy, we also stopped her linezolid tablet. We also did a neurologist reference, and we did her nerve conduction studies that came out to be normal. And by the neurologist tablet, pregabalin was added. However, only after stopping linezolid, the symptoms of her peripheral neuropathy were gradually subsiding. So we decided to not again reintroduce it. However, tablet cycloserine was restarted, and she was tolerating it well this time. Next slide, please. So at present, she has completed around 11 months of AKT. We started it in June 2024.
One second, Dr. Neeta, Madam Urvashi has raised her hand. She is asking something.
Sure, ma'am.
Sorry, I've missed it in my last bit that though the gene expert picked MTB, the co-infection with the mycobacteria can also not be ruled out always. So again, keeping that in mind, especially when there's a cavity, clearly showing, if there is the possibility of co-infection, which we can deal with. Yeah, why don't you complete and then I can come back.
Okay, ma'am.
Previous said December 25.
Okay.
Talk
Ma'am,
about-
previous slide. Oh yeah, previous. Yeah, I think we just went towards the end. Previous slide.
One slide previous to this.
Yeah. So yeah. So we did the third bronchoscopy. Next slide.
Next slide.
Yeah.
Next slide. Next.
Yeah, next slide. Yeah, we skipped this slide, the next slide.
Next.
Yeah,
yes,
this one.
Yes.
Yeah.
Hold.
So this is December 2024, sorry. So patient completed 6 months of AKT from June 2024 to December 2024. Patient has completed 6 months of all oral longer regimen. So a decision to extend Delaminate and Bedaquiline was done. So it was extended for more 6 months. And current AKT that was there was Bedaquiline, Delaminate, Moxihydrose, cycloserine, and clofazimine. Ethionamide was stopped initially because of resistance, and linezolid was stopped because of peripheral neuropathy. So now her recent follow-up was in February 2025. So patient is doing well. There is no cough. The appetite is also good now. Weight now is 74 kgs, which was initially 70 kgs. And we also repeated a CT chest now. So a comparative study was done. So the previously visualized centrilobular nodules have regressed much.
Next
And
slide,
even
please.
next slide. And even we can appreciate in the next slide, the CT scan images available. Yeah. So if we go back to the April 2024 CT scan, there was a left lower lobe dense cavitatory consolidation. So we started her in June on AOL based BDQ based regimen along with Delaminate and other drugs. So we see the left lower lobe cavity that is significantly resolved. And now, next slide. Yeah. So now in April, the patient has completed around 11 months of AKT now. Now her weight is increased to 78 kgs. So from 70, then to 74, and now it is 78 kgs. We also did her follow-up sputum AFB culture, which is no growth at 6 weeks. So now the patient has a good clinical, radiological, and even a microbiological response. So this is towards the end of my presentation. So the questions that I would like to ask my experts. First question is the discordance in the DST, the genotypic and the phenotypic DST that we had in view of ethionamide resistance. The expert XTR showed ethionamide sensitivity, and the DST that came along was ethionamide resistance. So I would like to ask that question. Second question is, we decided to repeat the bronchoscopy when she had come to us. Already, the previous bronchoscopy was done a month before only. So was the decision correct? And the reason it came positive when we did the bronchoscopy, what would that be? And the third question being, should we have given carbapenems in the regimen? So I would like to direct these questions to my experts.
Thank you, Dr. Sharvili, for the excellent presentation. So before we take up your questions with the experts, are there any questions for Dr. Sharvili?
Ma'am, may I ask a
Yeah,
few
sure,
questions?
Dr. Ankur.
Ma'am, my first question is, despite the initial 6 months good response on the bedaquiline delaminate combination regime, my question is, why the decision was made to extend both bedaquiline and delaminate in this case? What was the reason for extending both? And second question is, should we extend only one drug because in a improving case, in a patient who's getting better, and the main reason that patient is responding to this patient was probably this time the patient must be having a poor a good compliance with the treatment. So what was the reason to start both bedaquiline and delaminate? Extend both bedaquiline and delaminate in this case. And the second question is regarding moxifloxacin. If we have added, what was the reason to continue with moxifloxacin? Thank you.
Can I take this question, Dr. Singla?
Sure, Doctor.
Yes, Dr. Alba.
Yeah, so the thing is that here you are talking of one, the regimen. Second, you are talking of why extension for bedaquiline and delaminate. Now, if you go back to the history, you will see here she's a young girl who has already been taking treatment for 3 years. First, failed first line AKT, then the improper regimen of second line AKT with inferior dosages. And now it's a third time that we are putting this patient on treatment. So it's just that now it's the last chance she has to recover from her illness, which has already, been delayed, and she's developed underdosages. She has defaulted on multiple times. So here we had to be very careful with right selection of the drug, which is based on the previous history of the drugs that she has taken and based on the DSC that is available with us. So here, when we are, changing the failing regimen, because when she came to us and we did the bronchoscopy the third, we can see the gene expert is showing resistance, expert XDR is showing extended resistance even to low dose fluoroquinolone and to aminoglycosides also, and which was later on confirmed by phenotypic DST. So we have to add these 3 or 4 drugs which are not used by the patient previously, or the DST is showing sensitivity. So in that sense, we had to add bedaquiline and delaminate both. We initially gave ethionamide because their sensitivity was showing on this, but later on in phenotypic DST, it turned out to be resistant. We had to give high dose moxifloxacin because that was showing sensitivity both on phenotypic and on expert XDR. So, and later on, as the treatment went on, we had to, for the time being, stop cycloserine. And currently, we do not know whether cycloserine is acting or no because we do not have the DST, and she's already used cycloserine before. And we have linezolid, which we had to stop because of neuropathy. So now we have limited options available to complete her treatment. So even though she has shown good clinical and radiological response, we cannot take any chances. And we have to extend both bedaquiline and delaminate, which are very powerful drugs, which are not used by her before, to the complete duration of the treatment. Okay.
Dr. Alpa, there is a question that have you put the BDQ delaminate DST for this patient?
No, we haven't done.
Since she's responding, they should be sensitive anyway because she's responding.
Dr. Neeta, can I respond to the question?
Sure, ma'am.
For another meeting. So the first question is very simple. There is phenotypic genotypic discordance here because gene expert XDR only picks up ethionamide resistance in 60% of the cases, meaning the rest 40% is missed by XDR. So we should rely on the phenotypic DST. As it is, phenotypic remains the gold standard. Genotypic is trying to get there, but then in the newer drugs, we don't even know all the mutations. Hence, so that would be my answer to the first question. Rest, of course, Dr. Singla sir is here and other experts are here to guide.
So, any other questions on?
My only question is, because we are going in for zero catastrophic expenditure, right, this year. So how much approximate cost this patient has incurred for her management? Approximate.
For her treatment?
Yeah. How much cost this patient might have incurred for her management, right from 2022?
Yeah, I think it must be at least 3.5 to 4 lakhs.
Okay. Thank you.
So, Dr. Alpa, that would primarily because of 2 reasons. One, patient's own non-compliance to the treatment, and hence there is accumulation of resistance, as we can see. and the doctors are trying to find a way out for a patient who herself is not caring for her own health. Number two, of course, what I raised right in the beginning, the guidelines have not been followed by the private sector who initiated the first treatment. And had resistance been caught then, the right regimen initiated. That is why the program works so hard to offer upfront NAT. And we, during the campaign, as everyone is aware, we were pushing for 100% upfront NAT. And the provisions were made to states. We strongly urged them. And like I said previously, this was for asymptomatic population whose X-rays detected any abnormal shadow. So when it is a symptomatic population, we could in fact straight away do a NAT. And when the provision is there, also I would like to say Mumbai is one model city where the tie-up between the private sector and the program works beautifully. So there are private sector physicians who would collect the sample and send to the government facility. So we would like to have more such collaborations in place, and we request you, Dr. to get the private sector in the city onboarded with the state TB program, who can then assist you in free diagnostics. Free drugs can be given to the patient. Drugs can be stocked up in the private hospital. Those directives are in place and they're working in several settings. I'm not really sure which setting she went to.
So I would like to just share that after patient.
Let me just finish. Also, the patient gets the other benefits, the NPY benefit, the Nikshay Mitra benefit. If the patient needs, EDNS, or if he needs admission. Also, we like, the private sector to actually come forth and tie up with the program in every possible manner. Follow all program guidelines. We are now requesting our peripheral level workers, ASHA workers, to do differentiated TB care. So if that is where we are reaching, we would highly appreciate that we bridge this gap between the private sector physician and the TB program. So where experts like yourself can actually play an important role, do CMEs. We will be happy to do CMEs and still, bridge this gap so that the program guidelines reach those patients who are reaching the private sector as well. Thank you.
Thank you, madam. And really appreciate this suggestion. And that's the reason why I wanted to present this case that, private public partnership can really benefit the patient. So once patient came to our OPD, after diagnosis, we referred the patient to the public sector, and the patients procure the right regimen, and the drugs were given, and even counseling support he received from the program. And then she continued to follow up here with us in the private sector because she was comfortable following up here, where our ADR managements and everything was managed. So this is where, and in fact, we do have collaboration here with the public sector, that even some patients who cannot afford expensive investigation like bronchoscopy, they do have tie-up with some centers where, patients are referred for undergoing an invasive test like bronchoscopy, and then the cost is, taken care of by the program. So it's just that people who are working in the private sector should know the right way to approach the program, and even the district TB officers and all, they can, communicate with the private sector and make them comfortable. And that is, where win-win situation, because a young girl like this who lost her, valuable years, he had to take a, break from her career. And this was one of the reasons for her undergoing depression. And because of the inadequate or improper regimen and multiple ADRs, this was also contributing to her default. And all these gaps can be bridged, and the extensive costs that the family had to bear, and that can be bridged by more private-public collaboration. And Dr. Urvashi, madam, I'll definitely take your suggestions, and we would arrange for CME to create this awareness amongst the practitioners in private sector.
Alpa, last question from my side. Is there any information on contact tracing of this patient and investigation?
Yeah, so we did the contact tracing for the family members,
Yeah.
and they are following up regularly. So radiological and clinical evaluation was done, and it didn't show any positive cases, and no symptoms so far in 11 months that she's been with us.
And TPT.
The family members in the family.
Anybody started with TPT in the family?
No.
Thank you, Dr. Alpa. There are two questions for you. One is there a need for therapeutic drug monitoring? Number one. And the second is, how long can we give bedaquiline and pretominate? Not pretominate, it's delaminate, sorry.
Yeah, so you can give bedaquiline and delaminate if required to the entire duration of the treatment, which I would very much prefer in this case. I would not like to take any chances and stop one of the drugs and risk the regimen being lesser effective. So that's one thing. And we have used in number of patients where they have got extensive drug resistance or extensive disease and a long-standing disease, and it is pretty safe in terms of toxicity as well as tolerance. So that is one thing. What was the second question?
TDM, need for TDM, therapeutic drug monitoring.
So ideally, yes, therapeutic drug monitoring is important, especially in a case like this who had received lower dosages in the past. So amongst the second line drugs, we have therapeutic drug monitoring for clofazimine, for levofloxacin, for moxifloxacin, for bedaquiline, and for linezolid, and for aminoglycoside. So that is available, but currently that's not done in the public sector, and it is pretty expensive, almost around 3,000 to 4,000 per drug. So not every patient can afford that, but ideally, yes, if it's available in the program or if the patient is affording, then we must do.
Right, and there's another question that since patient had taken Moxi low dose for a long time, why did you decide to give Moxi again?
So here
again, high dose.
Yeah, again, you can refer back to the DST that we did initially. So Expert XDR did show that Moxi high dose was sensitive. It was only low level resistance. And then later on, it was confirmed on phenotypic DST also that moxifloxacin high dose was sensitive. So in a situation like this, we are desperate to use all the drugs which are available and which are showing sensitivity. So, the drugs which were not used previously and the drugs which were showing sensitivity despite of being used, and luckily even linezolid and clofazimine which were used before, but it was showing sensitivity. So we continued to use those drugs, and she's shown good response, clinical as well as radiological and microbiological.
Thank you. Are there any more questions from the audience? Dr. Alpa, do you need to add more? Do you want to, or do I ask Dr. Singla to give his comments?
Okay, so just here, one thing I would like to say that when the patient came to us, a decision of doing a repeat bronchoscopy was a little challenging because, when most of the time when you have a bronchoscopy report and that's showing smear and gene expression negative, most of the time you would not like to, or you may not think of repeating the bronchoscopy in such a short time. And also a question that why a bronchoscopy would have shown a negative result. So here again, I say the way of doing bronchoscopy would be important. When you are doing a bronchoscopy and lavage in such a patient, the targeting the right segment and the right lobe and sampling properly is important. Sometimes if you don't sample it properly, or too much of, it's diluted too much, it's possible that results may come negative, though it's not very common. But that's why in her case, we decided that even after being treated for Pseudomonas and the symptoms and radiological presentation very much in favor of TB, we thought that it would be best for them to convince to spend in doing this invasive test, undergo invasive test. But that I think was a turning point which gave us quick results, and we were able to take the decision of right regimen.
Hello.
Dr. Alpa. So we started with, there is a question. Yes.
Ma'am, actually one question query was there. So when from the bowel fluid, the result has given the reef resistance. So from that we can, in the concentration method, we could have done the LPA. So we have not done that
Yeah.
LPA. Okay, ma'am.
We did expert XCR.
So for confirmatory more better, so LPA could have been done. So from that same fluid, so by concentrating method, so you could have done that LPA. Of course, it is XA.
What advantage?
Pardon, madam?
Advantage you think it's over expert
Yeah, madam.
XCR?
So actually, because they routinely in the LPA, sometimes we consider because this is a more elaboratively we can study the by the through pro. So the situation could have been better, we could have elaborately could have diagnosed actually what is the resistance, why the mutations and all the things. So I thought that it could have been done because in our setups, so whenever like from the ball fluids where we are getting, so by making it concentrate methods from directly LPA, a couple of more number of cases also we have got it. So that is why just because you are higher center. So this is one of my suggestions from my last 10 years experience which I am doing here. So it could have been done.
Maybe Dr.
Dr.
Rupat Singla.
Alpa, I agree with Dr. because under the program, LPA is being done. And thank you to him for sharing his experience. It will work. So under the program, since LPA is available widely, I think we are okay with it. So, yeah.
Okay.
Dr. Sharveri had put up three questions. What about discordance in genotypic and phenotypic, especially for ethionamide, which Dr. Urvashi ma'am has very rightly answered, saying that phenotypic is the gold standard and genotypic is trying to reach there. So there is a chance that you can miss that. Then your second question was on decision of bronchoscopy, which Dr. Alpa has already, has answered. So now going ahead with third question, Dr. Singla, to you that, the decision on imipinam, what should be the decision? And also we have a question on drug modification as per the present weight of the patient. So I request you to take these two questions.
Okay, let me take the case from the beginning. You see, first of all, if we start from the beginning, in July 22, patient is diagnosed based on the radiology, that is CT scan, and this sputum was not done. As Dr. Ubuchi also said, in our era of universal DSP, at least plain simple sputum CBNet should have been done, which was not done. The patient was given 4 drugs, the first line drugs. After 2 months, September 22, it was found that there is no clinical improvement. They did again repeat CT scan. In a young girl doing repeated CT scans, I don't know what was the need. They should have done the X-ray both the times, and if required, CT scan should have been done. Anyway, and the BAL was done, bronchoscopy and bronchoaerial lavage. It showed MTB detected low and rifampicin resistance. Subsequent to this, the treating physician in the private sector, they started the patient in September 22 on a regime kanamycin, which was stopped after 4 months, ethionamide, Tericox, Monopass, clofazimine, linezolid, and moxifloxacin. Total, it was given for 18 months. You see here, this is the time when the treating physician should have joined hands with the public sector, and the correct regimen in this case could have been given. Number one, I'll come to that. Secondly, you see, giving ethionamide with Monopass, I can challenge any one of us joining this, very, very difficult to tolerate. And that could have been the reason for repeated defaulter by the patient. This combination should always be avoided if possible. Very difficult to tolerate. And even the dosage was not appropriate. So now next, please. So ideally speaking, at this stage, if you could have joined hands with the public sector, the ideal regime could have been the longer oral regime, which contains bedaquiline, and in this bedaquiline was not there. The shorter regimen, oral bedaquiline containing 9 months regime could not be given. because patient had disseminated disease, that is pulmonary TB and mediastinal lymph node. And at that time, the fluoroquinolone resistance was not known. Next. Now, after this, in April 24, that is 18 months of treatment, and kanamycin stopped after 4 months. As mentioned, patient had frequent default from the treatment. Even the moxifloxacin was taken irregularly, and there was no response with these medications. And CT scan, when was repeated, it was deteriorated, and now cavity was also there. Again, the repeat bronchoscopy was done, and the ball showed CBNet, and the CBNet was done, MTB not detected. And we are not sure, you see, once there is a cavitated disease, patient is deteriorating on a particular regime, we expect in these cases, especially in a cavitated disease, that the number of bacteria could be very high. MTB should have been detected. Maybe it was not done appropriately. Maybe they did not target the exact lower segment of the lung which was showing cavity. Otherwise, chances of missing they should have been less. Then, since kanamycin had been stopped, the treating physician continued with ethionamide, Tericox, Monopass, Propa, Linezolid, and Moxi. You see, if somebody has taken 18 months, clinically deteriorating, the X-ray is deteriorating. So, giving beyond 18 months, I think this is I don't know what word to use for it. It is not correct. It is definitely medical legally also it is not correct. It should not have been done. Then in June 24, patient fortunately reported to Jupiter Hospital under care of Dr. Alpa. And as in their presentation also they mentioned that they observed there was no response despite this almost 20 months of NDTB treatment. They decided to go for the FOB. Next. You see again, as has been discussed, why third FOB? Number one, as we already discussed, patient is deteriorating, patient is on medication, the cavity disease is coming. So, lot of chance that we have not hit the disease segment of our globe of the lung. So, one reason was that. Secondly, the third FOB could have been done was, and as of now, we did not know the resistance to INX, ethionamide, fluoroquinolone, and secondary injectable. That was another. And third, of course, is to obtain a sample so that we can get the culture and DST for all the drugs. And as Dr. Uruchi has also been mentioning in many of our clinics, that we also look for the atypical mycobacterium in such cases. So these things could have been done by the third bronchoscopy, and I think Dr. Alpa did that, keeping these things in mind. Next. When the report came of the bronchioral lavage, it showed MTB detected low, rifampicin resistance, and the expert XGR was done, which showed resistance to INH, fluoroquinolone, low level, and second-line injectables, and it was sensitive to ethionamide, and the culture was awaited in June 24. Next. So in June 24, the empirical regime was started, containing bedaquiline, delamanid, high-dose moxi, linezolid, cycloserine, clofazimine, and ethionamide. And this, Dr. Alpa could join hands with the NTEP, as she has been doing for, I think, for so many years. And she is a typical example of a good public-private mix model in Mumbai, so that her patients get the best of treatment available, including the newer drugs. But I have some comments on this regimen next. You see, here is a patient who has been taking moxifloxacin, linezolid, cycloserine, clofazimine, ethionamide for almost 20 years. And there has not been any clinical response, any radiological response, or other deterioration. So I'll consider that these drugs are not reliable to be taken as a part of the regime. Because when we are making a regime, we have the drugs which are likely to be effective, and there are drugs which could be effective, but we are not sure about that. Because if somebody is taking 20 months and deteriorating, I believe that these drugs are not acting unless proved otherwise. And these three drugs, besides these three drugs were added, bedaquiline, delamanid, and high-dose moxi as the neo drugs, the additional drugs. Bedaquiline had never been taken, and a good bactericidal sterilizing drug. Delamanid had never been taken, again a good bactericidal and the sterilizing drug. Regarding moxi, till that time, you see the XGR, expert XGR had shown that the moxi low level is resistance, but moxi high could be efficacious. We all know that whenever we talk about the moxie high dose, the effectivity or the sensitivity, as per the LPA document, it has to be reconfirmed by the phenotypic method. So, and we have been found in our country also that there is a significant amount of discordance between the genotypic and phenotypic regarding the moxifloxacin resistance pattern. Anyway, I think Dr. Alpa group was cornered. Not much medicines were available. So they had to continue the rest of the medicine along with these bedaquiline delamanid and moxi high dose awaiting the culture report. Another thing is, if I was a treating physician, I could have tried to add injection imipenem and cilastatin so that the regimen could have been strengthened. Although we all know there are significant logistic challenges, not only the cost, requirement of a PICC line to be inserted, then infusion to be given in the morning, infusion to be given in the evening. But considering the young age of the patient, deteriorating with the second line drugs, cavities are developing now, which could lead to total lung damage. So I think we could have tried this also, and Dr. Alpayas put up this question also that whether it could have been considered. I feel that it could have been considered. If in case you give imipenem cilastatin, then there will be 8 medicines. So in that case, I'd like to stop isoniazid because it has been used for such a long time. It's a bacteriostatic drug, and again, this will reduce the pill burden also. And also giving PAS and isoniazid together, that will be avoided. Next. On July 24, the culture report of the sample submitted earlier that was available, it showed MTB positive, and the DST showed resistance to INH, rifampicin, ethambutol, pyrazinamide, and all the 3 injectables, as well as isoniazid, and sensitive to PAS, clofazimine, moxi high dose, and linezolid. And in July, based on this report, the regime of bedaquiline, delamanid, moxi high dose, linezolid, cycloserine, clofazimine was continued, and isoniazid was stopped, looking at the DST that isoniazid is resistant. Next. You see again, if we talk about this regime, again these 4 drugs, moxi, linezolid, clofa, and cyclo, they have been used for 20 months without any clinical, radiological, or microbiological response. So I'll treat them not as a reliable drug. So practically 2 reliable drugs, bedaquiline and delamanid, and in case we consider moxifloxacin also, although she had been taking moxifloxacin normal dose for quite a long time, it would be 3. Ideally, I'll take only bedaquiline delamanid as the effective drug, and regarding the reliability of the isoniazid resistance by expert XDR, which I discussed with Dr. Urvashi in the morning itself. Whenever we are cornered about any microbiological issue, she is there to help us, and I text her in the morning. I got the reply within 2 minutes that there is a regarding isoniazid resistance. It is concordance with the phenotypic is just not more than around 60-70%. So that is seen in this case also. Next. So with this regime continuing in September 24, there were seen symptoms. As discussed in the history, the cycloserine was stopped temporarily and put on antipsychotic treatments. October, there was peripheral neuropathy. Linezolid had to be stopped for the rest of the duration. And October, November, again the cycloserine could be restarted. In December, patient completed 6 months. So the Dr. Alpar group, they decided, rightly so, to extend bedaquiline as well as delamanid. Otherwise, we could have had a very, very poor continuation phase. So bedaquiline, delamanid, moxi high dose, cycloserine, clofazimine, and they repeated the CT in February 25, which showed significant improvement. And today, in April, patient is having a good clinical response, and the sputum cultures are negative. You see, here I'd like to say, yes, we agree, although nothing succeeds like success. This patient has practically improved radiologically, clinically, and this. But still given a choice, as a basic dictum, and through this difficult to treat TB forum, we just again want to spread this message that whenever we are facing a case who is not responding to treatment clinically, radiologically, if possible, we should add at least 3 to 4 new reliable drugs. Reliable means which are likely to be reliable, that patient has not taken them, the lab is saying that they are sensitive. So this is the group where we say that the drugs are reliable. So they should be added to a failing regime. And if a patient has taken for treatment for drugs for 18 to 20 months, even immediate DST says it is sensitive, we should take it with a pinch of salt. We should interpret it carefully because, especially for the second line drugs, the widget DST may not detect resistance 100%. So if a patient has taken these drugs for quite a long time and widget is sensitive, they cannot be called as reliable drugs. When we're choosing, they will not be counted as reliable drugs. Okay, we'll give them in case we are cornered, but they should not be treated as reliable drugs. So this message also I want to convey through this. And I must thank Dr. Alpa for picking up this case at a very short notice. And she has demonstrated how public-private partnership can help, and also how the regimen should be made in these type of cases where it is difficult to have medicines with you. But I think she did this case very well. Congratulations to her. And of course, I would like to thank Dr. Urvashi also, that she is always there to guide us, not only in microbiological aspects, but also for the programmatic aspects. So thank you, Dr. Urvashi, to you also. Thank you very much.
Thank you, Dr. Singla. Dr. Shavri, I hope all your questions are answered. And, Dr.
Yes, ma'am,
Alpana,
definitely.
yeah.
Yes, ma'am. It was great learning from all the experts today, and I'm very thankful for the opportunity to let me present this case. Thank you so much.
So are there any queries, still any queries or any doubts that you would like to ask or any comments? So I think this case has, very nicely has discussed the importance of public-private partnership. It is a very important case, how a difficult case should be managed at medical colleges or at nodal DRTB centers. So this also tells us the importance of forming these DRTB committee. We have Dr. Bharadwaj with us, and has decided that every medical college should have a DRTB committee where the private practitioners as well as the DTOs can refer their difficult cases for the opinion and management. If this patient, as it reached to Dr. Alpa in the private sector, she got the right treatment now. But if she had gone earlier, she would have got the right treatment at the onset. There would have been lesser cost of treatment, lesser ADRs, and less psychological trauma. Patient would have got the benefit of NPY or the DBT. Every month we pay 1,000 rupees per month to the patient till they are on treatment. Patient would have got admission into a good facility free of cost. And of course, there would not have been so many interruptions and defaulters that this patient had. So there is a win-win situation, as Dr. Alpa had commented, saying that if private practitioners and public partnerships are there, then it is a win-win situation for both. And then comes the role of state and DTOs, where we need to do the advocacy of the program among the private practitioners and build up that goodwill and trust among them that, together we can really help patients in their treatment. So with this, I thank, sorry.
Yes, one small thing. Dr. Bharadwaj had asked about the TPT in this case. You see, as Dr. Alpa informed us, they have examined the contracts clinically as well as radiologically. They are following them up. Now, in India, as of today, for the drug-resistant TB patients, the TPT which is recommended is 6 months of levofloxacin, provided the index case is levofloxacin sensitive. But because in this case, the index case is having levofloxacin resistance, so in this particular patient, the TPT for drug-resistant TB will not be applicable. Thank you.
So thank you. Yeah. Yes, Dr. Alpa?
Yeah, so as you rightly said, that public-private partnership, and this is the gap we need to bridge, because what we see that even in today's era when we have everything available, patient is not getting the right investigation of universal DST to the not getting the right regimen, and that is something which is really troubling to see in this time. So many of the people practicing in the private sectors are maybe not aware of the guidelines or the newer dosages, and there is some inhibition from their side to approach the program, because one, they don't know whom to approach. Second, maybe a feeling that, okay, if I send the patient to the program, that patient will get lost. Patient also have this feeling that if we go to the public sector, we'll get lost. We don't know whether they'll be taken care of. So this is the reason I think patients are not being referred and given the right kind of treatment which is available without cost in the program. And luckily for this patient, she wasn't nutritionally she was good. She's coming from a good family, so the disease remained limited. But we've seen number of cases where such amount of time is wasted. So it was almost 2 years before she came to us. Patient get extensive disease, bilateral disease, extensive lung damage, and many a times even after coming to us and getting the right regimen doesn't help them because they've already lost a lot of lungs by then. So this is a very common scenario. So I think really something we need to do from our side, from the program side, maybe have communication channels. Here we in the city of Thane, we have very good communication channel between the CTTB officer and even the staff which is working in the DRTB center, and that makes us very comfortable as a private practitioner to refer our patient to. Then we know that they will communicate with us, right? Whatever regimen we advise and whatever input they have, they will give it to us. Patient will continue to follow up with us to manage the ADR, and I think this is very important. I don't expect that private practitioner will really reach out, but somehow, if, as madam also suggested, Urvashi madam, somehow we can reach out to them and develop that communication channel and make them comfortable referring that patient to the public sector. I think it will go a long way to save lives and morbidity as well as mortality in this young patients.
Thank you,
Professor,
Doctor.
Professor Shingla, this is Professor Shakil from Dhaka. Can I speak a little bit?
Yes, sir, most welcome.
Thank you very much. Dr. Alpa, it's very pleasing to listen to your talk, and moreover, the patient has got improvement. That's our ultimate satisfaction. And I can see the face of different people who are also happy with the work you have done for the patients. And all of you have rightly commented that the communication between the program and the private sector is hanging somewhere in some services. Everybody is trying to do, government is putting money over there. Even in Bangladesh, we are putting money over there. Despite that, the things are not happening. So as we know, the private sector will not be keen to communicate in that side. Now it's on us, is on our side as a program personnel to know what are the lacunas where we cannot reach. And I would request Professor Shingla in this case that you conduct a good qualitative research through which we can understand what are the hindrances and what are the fallbacks there are, that also you can, not only India can learn, other countries can learn as well. Thank you very much. Once again, thank you, Alpa, for your excellent work.
Thank you, sir. Thank you.
Thank you, Dr. Alpa and Dr. Shakil Ahmed, sir. I think one question that remained unanswered was about the doses of the drugs that are being given. So your comments, Dr. Singla?
Yes, you see, patient is more than 70 kg. And if you go by the guideline, the dosages, it says cycloserine to be 1000 milligram, clofazimine more than 70 should be 200 milligram. Yes, it is mentioned there, but let me tell you, cycloserine more than 750 is very difficult to tolerate. And already in this patient, she has had episodes of depression and she required antipsychotic medicines. So I think as a physician, we have to leave it to Dr. Alpa to really see whether to increase the dose to 1000 milligram or not, or she would like to do it gradually, because we have to be realistic also. And all of us who have been treating cycloserine, the medicines, using cycloserine, it becomes difficult to tolerate it. Same thing you see with clofazimine. She's on 100 milligram, to give 200 milligram We are all aware she is a young girl, and it makes the skin look very brownish, black, very much scaly. And personally, I'm always not very much in favor of this drug. That it's a very bad experience for the patient to have, and nobody would like at a younger age to look sort of black and with a dry skin and also photosensitivity and all that. But in this case, I think we do not have a choice. But again, the dosage increased to 200 milligram. I think in case we are giving, we may increase to 200 milligram. Also for cycloserine, I think we have to leave it to Dr. Alpa as a clinician to decide and when to increase or to continue the same. That is my feeling for it. Thank you. Dr. Alpa, would you like to?
No, I agree with you, sir, clofazimine. And here I think somebody mentioned about the therapeutic drug monitoring. I think that would be important. We can do therapeutic drug levels, and if with 100 also the drug levels are maintained, then we may continue the same dose and otherwise increase it to 200.
Only issue is this the TDM for the second line drugs reliably is not available in most of the places. That is the issue.
Yes.
But anyway, I think for discussion.
I think that's a suggestion. That's a valid suggestion. It's missed out. I think when she gained weight from 70 to 78, we should have thought of increasing the clofa to 200.
Thank you.
Thank you.
Thank you, Dr. Alpa. Now I invite Dr. Bharadwaj sir. Dr. Ashok Bharadwaj sir is the chairperson for the National Task Force for Medical Involvement of Medical Colleges. So over to you, sir, for your.
Thank you, Nita. So first of all, I congratulate Dr. Alpa and her team. So the question which I asked was prior to the patient landed in your hospital. So it was all mismanagement. It's not none of your fault, but it was all mismanagement. I echo the words of Dr. Urushi madam, because we have to somewhere follow the guidelines. So I think in your city it is CTO. So CTO has to ensure that the guidelines are being followed and the private practitioner are brought on board. So I know you write from 2021 when I took over as NTF. So you are working very hard, honestly, in your institution. So, but we have to look into the patient. We are going to these private practitioners. So yes, there is a necessity of capacity building of these persons. So they are not immune to this. They just can respond to it. So we should have in regular basis the capacity building, because the guidelines are coming up, new guidelines just like VPOL and the EPTV guidelines, and these guidelines has to be disseminated to all these private practitioners, because if we look into the data, majority of the patients first land with them. So if the patient is mismanaged at that level, then it will come to this level, which you have to do a lot for that. So thank you for doing a wonderful job. I again say that we have to reduce the catastrophic expenditure. So we have to have liaison with the public sector so that patients do not spend much. So thank you very much. Thank you, Nita, for giving me a chance. It was a wonderful learning for me. Whenever I hear Urushi madam also, I learn something more, and I also write it. So so that I cannot forget it. So it's always learning, whatever may be your age, but you learn at each age. So thank you, Nita. Thank you, Dr. Rupak, and thank you, Alpa, for wonderful comments as well as wonderful interesting case. Thank you very much.
Thank you, sir. So with this, we come to the end of our clinic. I request you all to give your feedback. It is very, very important for us to improve our future clinics. The feedback link is in your chat box, so kindly give your feedback. And I thank the team from Mumbai, Dr. Alpa, Dr. Sharvari. I thank Dr. Singla, Dr. Urvashi madam, and our director, and all the participants who attended this clinic. Thank you very much, and we look forward to meeting you in our next clinic. Thank you.
Thank you. Thank you for this opportunity.
चीनी मैं बनाई दीजिए सांस का